It's a pleasure to be here at the University of Oslo, and I'm very much looking forward to the next couple of days as well. So I was asked to speak on how do we get SRHR on the national and global agenda. And keeping in mind what the Rector Ole-Petter just exhorted us a couple of hours ago, is to ask questions and even more questions and look at the complexity of the issue. I'm going to slightly modify the topic of my presentation and ask the question, do we want more of the same? As has been repeated by several speakers before me, the ICPD was a hard-won battle, and it did definitely go beyond the right to health services. And it brought in the very important issues of the rights of women and girls to bodily integrity, autonomy, and choice. And I think that's kind of going beyond just a question of providing the health services that are needed. And I think we need to remember that when we say, oh, we have the evidence of what works, because it's not just evidence of which health services are needed, but it's also about how they actually play out and what are the kind of, the boundaries in terms of women's rights in that particular context, rights to choice and autonomy and agency. Of course, we all know what ICPD did not do. Speakers have mentioned about the challenges regarding young people's rights and also the whole difficult issue around sexual rights. What about the MDGs? And I think we must remember after the ICPD that everyone agreed, based on the WHO formulation, that reproductive and sexual health needed 4 core components. And it's interesting that the MDGs were formulated without, initially, a goal on sexual and reproductive health and rights. They just included the first component, which was maternity care. And, well, this was rectified after many protests by the women's rights and the health rights movements on bringing in the additional target 5B. But what are we going to look forward? What have the current global processes done in terms of, what is coming out from the open working groups? We've seen that there are sexual and reproductive health and reproductive rights mentioned within a couple of the targets in 2 of the goals. But what really are we saying? Are we saying we want more of the same? Or are we saying we've learned some lessons from the last couple of decades and we need to think about how we could do it differently? And that's the question I'm going to ask today. So I just want to start with a story of someone who is at the bottom of the food chain, so to speak, a person who is at sort of the final interface of policies and evidence and programs and the real world. So this is a story of someone whose name I've changed, but we just came across her case a few days ago, and I thought I would share it with you because it seemed to reflect to me some of the very big questions that we are facing today. So she is from a backward community. She is a daily wage earner, which means that the family earns barely $1 or $1.50 a day. She was pregnant at 16. Okay, we've been talking about youth reproductive health. And within the next, 14 or 15 years, she already had 4 children. And in India, the real option in terms of family planning services for poor women is to go in for the terminal method. And the terminal method is usually given after you have achieved what your local health worker thinks is a good family size. So it could be 2 children, or 3 children, or 4 children, or 2 boys, which is even more important. Okay, you have 2 sons, so let's go on and end this process of reproduction. So she had the sterilization surgery in 2008. It failed. And within the next couple of years, she was pregnant again. But she had fallen off the map of her local health worker because she had been sterilized. So she didn't need the services any further. So there was no attempt to follow her pregnancy, to find out why she became pregnant in the first place. There was no question of her rights. So she had this uncared pregnancy and she had childbirth at home. Well, she mentions that as being her one positive experience, that she had a perfectly safe childbirth at home, attended by a friendly neighboring woman, and she was fine, and the baby's fine. Well, again, within a couple of years, she was pregnant. And this time, the frontline worker kind of woke up to her reality, came and found out that she was pregnant, conducted the pregnancy test. Yes, the commodities are there. And then washed her hands of the whole affair, telling her, if you don't want the baby, well, go and have an abortion. And the frontline worker did not provide any further counseling or support. The question is, why did this happen? It's because our results-based, incentive-based payments for frontline workers do pay them for providing antenatal registration to women, do pay them for taking women to access contraceptive services, but do not pay them for any kind of abortion counseling. And so she didn't care. So Leela had to look around, and who was there in terms of the abortion service provider closest to home was the quack who gave her 5 pills and said, just take them, one each night, but as soon as you start bleeding, you must stop taking the pills. So basically what she did was she took 2 pills, she had an incomplete abortion, and then she bled for an entire month, by which time she was unable to work. And as I said, this is a family which is really on a subsistence level, and so her husband was concerned and took her to another private provider who gave her some medicines. So far, so good. The bleeding seemed to have stopped. But let's remember that family planning is a priority for the Indian government. It does incentivize its frontline workers to seek out women who might want the services. We do have FP 2020 goals of how many million women we want to show as covered by family planning services. And so, unfortunately, within 3 weeks of this incomplete abortion, the frontline worker found out about another sterilization camp being held close by and took her there. What about the doctor who saw her? The doctor said, there's something wrong. This woman actually needs a DNC, not a sterilization operation. I don't think I want to perform this surgery. But the frontline worker insisted that she had done a pregnancy test and this woman was not pregnant. And so, technically, she could go through the surgery. So despite contraindications, this doctor actually did perform a sterilization operation on her. And my question is why? Was this medical evidence? Clearly not. But there are other pressures at work, there are other contextual factors that we need to look at when we see this particular incident. Immediately after the surgery, she was bleeding heavily. And, her family says that she was changing her cloth more than 20 times a day. So you can imagine somebody from that kind of a poor background with very poor nutrition and what this is doing to her overall health status. Within a week, the frontline worker comes back, cuts her surgical stitches, and says, oh, you're bleeding. Well, okay, I can take you to a private doctor. Why does a state-provided frontline worker not take a woman who is suffering from complications of an unsafe and incomplete abortion into the state system? And here I think there are uncomfortable questions about the role of the private sector and the regulation or the lack of regulation of the private sector and the whole economy, the business of women's health. So we have the frontline worker taking her into a private hospital where she, who earns less than $1 a day, pays $160 to get what they call cleaning. So it's basically kind of DNC, and then she is admitted into the hospital because she's so weak and she's unable to even get up and go home. She comes back, she continues to be in extreme pain. So here is a post-abortion complication which was not actually dealt with effectively. The family then seeks out yet another private doctor. So what was wrong with the first private doctor? What kind of procedures were done? Were those incomplete procedures? Were those irrational procedures? We really don't know. The second private doctor once again charges $160 US. And the procedure is repeated. Today, when we actually went and found out what was wrong with her and why she was unable to work and sinking into even greater poverty, well, she's still bleeding heavily every month, and she is completely dysfunctional as an economic, productive member of society. And here's the question, how did this happen? So what are the issues arising here? What's been missing? We've had so many years of the MDG goals. We've had an Indian government which has been putting in a lot of budgets, a lot of workers, a lot of health sector reforms. We've had everything. I mean, the picture is much rosier than what we perhaps heard from Zimbabwe and Philippines. But yet, there's something going wrong. There's been a lot of global health wisdom that has been given to the Indian government about the best way to deal with women's reproductive lives. A lot of that has actually been implemented on the ground. What are the big questions that are arising here? I think the first question is a question of equity. And I think that is a question, it's a reflection on the entire process of the MDGs and the kind of measurements that was supported by the whole health metrics of the MDGs. The second question is around reproductive rights and the whole language of rights, human rights, choice, and quality. And here, I'm not just going to talk about the provider as kind of being evil, because there are also pressures on providers because of an overall system of accountability that does not respect rights. And finally, what do we understand by the words quality and accountability, and have they fallen off our radar somehow? What are we really measuring? And our measurements, do they contribute to a better quality of life for those who are most vulnerable and the poorest of the poor? So, well, we've talked about how the MDGs led to a lot of gains, but yet there has been very clear commentary that showed that these aggregate gains at the national level mask stark inequalities. And I think we've talked about how, I think Malcolm mentioned about how the USA itself also has very, very poor health indicators like maternal mortality in some areas. And the big question again is that, do poorest women have the ability to exercise their reproductive rights? Inequity consists of inequity in the way the gender imbalance continues, contraceptive choices have remained focused on women's methods, and contraceptive options are not really moving beyond that in the last 20 years. That's a question. Why does male method like sterilization either plateau or actually come down? And why is it that donor assistance is clearly preoccupied with infectious disease control? Is that what global public health is all about? Saving a few countries from the dirty diseases of the unwashed masses in other countries? And do rights and dignity not have any meaning for global public health? There are inequities in the way women die. Maternal health has gone down, but yes, let's remember it's gone down more in some countries and not in other regions. We need to remember the whole question of abortions and how, because it fell off the MDG map, it also fell off the map for a lot of governments. And then, of course, the big elephant in the room, what about the health systems? What has happened to health systems when you put in vertical interventions, when you talk about results-based financing, when you say there must be demand-side financing, provider incentives? What happens to health systems as a result of this obsession to measure? What's happening to rights and choices? What's happening to the kind of discrimination women face? And I think the significant human rights abuses that continue were also shown out very starkly in India a few months ago when 13 women died after undergoing sterilization operations in a district in central India. And I think many of you might have read the kind of news coverage that came out that received global attention. And yet, it was never raised as an issue when India hosted reproductive health conferences subsequently, because there was this kind of tacit approval of the other things India is doing, and so the rights violation should not be taken up. And we also have been talking about discrimination against adolescents. We've talked about that earlier, but also of unmarried people, people with diverse sexual orientation, and the fact that sexual rights have really not been taken up at all. What about providers? Are we actually equipping providers to provide full and accurate information? Is there really informed choice that's happening? And what about the incentives that we give providers in terms of promoting certain methods? So what did we fail to measure? Are there things that we need to still look at? What about the inequalities? What about the quality of services? Are we also looking at clinical standards, at ethical standards, and most important, at human rights standards. And I think we've been so busy looking for results, especially quicker results for those evidence-based interventions, that we somehow forget the health system costs that are incurred when we put in such vertical interventions, as opposed to putting in an integrated package of services. So the accountability mechanisms, no one's talking about accountability because they're not supposed to track the progress or redress inequalities and not to look at the quality violations and the rights violations. And the voices of the community really have no space. So without that kind of feedback, how are we actually assessing quality? Is it just based on the official reports? So I end with a plea to the young people here. Let's not have more of the same. What's the version 2.0 going to look like? I'm going to challenge you all as health researchers, public health activists, to consider how can we work with some of the old questions, which are the legal, social, and economic barriers that women and girls continue to face. What about sexual rights? And now, the newer challenges that are emerging, how can we increase service availability and access for those who are receiving it in the most inequitable situations for the disadvantaged and the poor? Also, how do we look at quality? How do we measure integration of services rather than continue to focus on the vertical measurement of specific solution-based techniques? And finally, what about accountability? Who's going to have the courage to bell the cat? Thank you very much, and I'm welcome to your questions.
Thank you, Jashodhara. I think we're going to open up for some questions or clarifications only right now, and then we're going to take the discussion in the end. So if you have questions for Jashodhara in terms of clarifications. Yes? I'm going to give you the mic so you can hear what you say. There you go.
Hi, my name is Pallavi and I'm a medical student here at the Oslo University. I was just wondering about these frontline workers you were talking about. Who are they and who takes charge of them?
Thank you for the question. These frontline workers are basically two kinds. There are those who have received training. They're called auxiliary nurse midwives, and they're part of the formal government system. Most of them have a regular pay. They're also based in health sub-centers in different villages. And then there are the sort of next level, which are more the community level frontline workers who are called ASHA. And these women are meant to be kind of tracking pregnant women in the villages and, you know, find out who needs to go in for registering their pregnancy or for, well, contraceptive services, etc. These are not paid a salary. They're paid based on their performance. So if you get a woman for an institutional hospitalized childbirth, you get paid so much. If you get her for a sterilization, you get paid so much. And they have very, very limited training. It's just a few weeks. And the quality of the training is very dubious.
Any other questions of clarification? We will have time for a discussion in the end, so just hold on to your questions.